Welcome. Today we're working through the 2025 AAP clinical report on the PDA in preterm infants, the update to the 2016 BNITS report. The framing to hold on to for the whole session: despite decades of trials in thousands of infants, we still don't have firm answers on which PDAs to treat, when, or how. The report's central message is one of equipoise. By the end, you should be able to define a hemodynamically significant PDA, summarize what the major RCTs showed, and explain why closing the duct has repeatedly failed to translate into better outcomes. This is pitched at fellow level, so I'll assume you know the basic anatomy and physiology, and we'll spend our time on evidence and decision-making. 4 anchors for the session. First, natural history. The single most important fact in this whole topic is that spontaneous closure is the norm, even in very immature infants, so any intervention has to beat a high spontaneous closure rate. Second, how we actually define a hemodynamically significant PDA, which is a composite judgment, not a cutoff. Third, the evidence base, a large Cochrane overview plus 3 modern non-inferiority style RCTs that all point the same direction. Fourth, the practical management menu and where each option sits. Keep asking yourself throughout, does this intervention change outcomes or just change the echo? Set the stakes. The report rests on an overview of 16 Cochrane systematic reviews, pooling 138 RCTs and nearly 12,000 infants. This is not a thin evidence base. And yet the punchline that runs through every section is that closing the duct reliably works mechanically, but has never been shown to improve the outcomes we actually care about: death, BPD, NEC, or neurodevelopment. That mismatch, effective at closure, ineffective at improving outcomes, is why practice varies so wildly between units and even between attendings in the same unit. When you see that variation as a fellow, it's not because people are careless, it's because the evidence genuinely underdetermines the decision. Natural history in numbers. In term infants, the duct is functionally closed in 90% by 48 hours. In preterms, the immature ductus is both less sensitive to oxygen-mediated constriction and more sensitive to the vasodilating prostaglandins still circulating. So the more immature the infant, the longer the duct stays open. The bar chart is worth memorizing. At day 4, roughly 10% of 30 to 37 weekers are still open, but 80% of 25 to 28 weekers, and over 90% of those at or below 24 weeks. By day 7, those rates fall sharply to about 2%, 65%, and 87%. The mechanism that makes a PDA harmful is the ductal steal. Once pulmonary vascular resistance drops, you get left-to-right shunting, pulmonary overcirculation, and diversion of systemic flow away from the gut, kidneys, and brain. Hold that mechanism. It's what every echo criterion is trying to capture. This is the slide that should change how you think. Spontaneous closure isn't a rare bailout, it's the dominant outcome. Above 28 weeks, about 3/4 close on their own. Above a kilo, 94%. Even at under 26 weeks, in the modern conservative era, around 90% close spontaneously, at a median of 36 weeks post-menstrual age. And of the babies who go home with a still patent duct, half close by 9 months and 80% by 2 years. The clinical consequence is unavoidable. Because the control group does so well, any drug or procedure has a very high bar to clear before it can show benefit. And as we'll see, most don't clear it. The TIP placebo data drive it home. Half the placebo infants, all under a kilo, never developed clinical signs at all. Every time you're tempted to treat, ask whether you'd just be treating a duct that was going to close anyway. Here's the conceptual heart of the controversy. There's a long list of bad outcomes that are statistically associated with a prolonged PDA: ventilation, BPD, pulmonary hemorrhage, NEC, renal dysfunction, IVH, PVL, cerebral palsy, and death. That list is real and consistent, but association is not causation. The persistent duct may itself cause harm through the steal physiology, or it may simply be a biomarker of the most immature, sickest infants, the same immaturity that independently produces all those complications. The field made an understandable inference. If the PDA tracks with harm, closing it early should reduce harm. Enormous effort went into trials designed to confirm that hypothesis. The recurring, humbling result is that closing the duct doesn't reliably move those outcomes, which is exactly what you'd expect if patency is largely a marker rather than a cause. That's the lens for the whole evidence section. There is, to date, no accurate and precise definition of a hemodynamically significant PDA. Internalize that. We triangulate. On exam, the classic continuous murmur, hyperdynamic precordium, and bounding or even palmar pulses suggest a large shunt. But every one of these is nonspecific and a poor standalone predictor. What actually drives most of us to the echo is the clinical footprint. An infant who can't come off respiratory support, or who shows signs of systemic hypoperfusion, hypotension needing pressors, oliguria, feeding intolerance. Biomarkers, BNP and NT-proBNP, have moderate accuracy and can help triage who gets imaged, but they're assay and population dependent, and the report is explicit that you must validate them locally before routine use. So significance is a clinical plus echo judgment, never a single test. This is figure 1 from the report, rebuilt. It's a clean mental checklist. For every PDA echo, ask 4 questions and know which measurements answer each. 1. How big is the shunt? That's PDA diameter and the Doppler flow pattern. 2. Is there left heart volume overload? LA to AO ratio and left ventricular output. 3. Is there pulmonary overcirculation? Same LA to AO and LVO, plus the end diastolic velocity in the left pulmonary artery. High diastolic forward flow in the LPA reflects runoff. 4. Is there systemic hypoperfusion? Look at descending aorta flow and the downstream organ beds, cerebral, renal, splanchnic, for decreased, absent, or reversed end diastolic flow, the Steele signature. Notably, a persistent PDA has even been linked to reduced preductal flow, reverse diastolic flow in the brachiocephalic artery, and lower middle cerebral artery velocity, so the Steele isn't purely a postductal phenomenon. Don't forget myocardial function. Diastolic dysfunction is common in these infants and amplifies the impact of the shunt. This is the table to take to the bedside, the report's suggested operational definition of an HSPDA. It deliberately requires both a clinical and an echo component, because neither alone is sufficient. On the clinical side, you need at least 2 of 4. Significant respiratory support, high CPAP or NIMV with high FiO2, or meaningful ventilator settings at any FiO2. Hypotension needing a vasopressor, persistent oliguria or renal dysfunction, or the gut picture, distension, feeding intolerance, poor growth, or prior NEC. On the echo side, you need at least 1 of 4. A minimum PDA diameter over 1.5 millimeters, unrestricted left to right flow, meaning a low velocity duct with peak velocity under 2 meters per second, left-sided volume overload with at least moderate LA or LV enlargement, or decreased, absent, or reversed end diastolic flow in the abdominal descending aorta. Again, the Steele. Note how this anchors significance to the infant's physiology and gestational postnatal context, not to a single diameter. Use it as a framework, not a rigid rule. This grid is the executive summary of the entire evidence section, and it's graded 1A for the headline outcomes. The consistent pattern? Yes, prostaglandin inhibitors close the duct. That's never been in doubt. But pooled across trials, closing it does not significantly reduce mortality, BPD, NEC, or neurodevelopmental impairment. The one real exception is severe IVH, which prophylactic indomethacin and ibuprofen do reduce, though that hasn't translated into better long-term neurodevelopment, partly because indomethacin prophylaxis also has its own effects. Why the disconnect between closure and outcomes? A few possibilities the report raises. The hemodynamic gain from closure may be offset by NSAID effects on the lung. Closure may only help specific disease endotypes we haven't identified. Or, again, patency may largely be a marker of immaturity. Whatever the mechanism, as a fellow, you should be able to state flatly that effective closure and improved outcomes are not the same claim. Prophylaxis means treating before you know the PDA status, usually in the first 3 days. Walk the agents. Indomethacin, the most studied, reliably cuts symptomatic PDA, surgical ligation, and severe IVH, but moves none of the outcomes that matter at 18 months to 3 years. Ibuprofen similarly reduces PDA, rescue treatment, and ligation, with a trend toward less severe IVH, but it increases oliguria and, again, doesn't change mortality or BPD. Acetaminophen beats placebo on closure, but with low certainty and no clear edge over the NSAIDs. The single prophylactic ligation trial is essentially historical, pre-surfactant, pre-antenatal steroid, 84 babies, and isn't generalizable. So the recommendation is clean. Prophylaxis is not recommended at any gestational age or birth weight for the purpose of reducing symptomatic PDA, because the downstream benefit isn't there. The IVH signal is real, but doesn't justify routine prophylaxis, given the outcome data and the NSAID exposure. Once you've decided to treat a symptomatic PDA, all 3 prostaglandin inhibitors work. The bar chart shows relative risk of failure to close versus no therapy, and lower is better. Indomethacin, RR about 0.30, acetaminophen about 0.35, ibuprofen about 0.62. But efficacy isn't the only axis. IV ibuprofen is frequently the preferred agent because it matches indomethacin for closure while being safer. Lower NEC with a number needed to benefit around 25, a trend toward less intestinal perforation, and significantly less oliguria. Standard dosing is 10, then 5 and 5 at 24-hour intervals. A few practice points. Combination therapy gives no added closure benefit and is graded 1A against. Don't stack drugs. A second course can raise the closure rate, a third rarely does, and adverse effects from extra courses are actually uncommon. High-dose oral ibuprofen improves closure odds in larger infants, but it hasn't been adequately studied under 29 weeks, so don't extrapolate it to your micropreemies. And remember the overarching caveat from the last slides. Closing it doesn't equal improving outcomes. These 3 trials are the backbone of the modern recommendation, and they rhyme. PDA Tolerate randomized infants under 28 weeks with a moderate to large PDA at days 6 to 14 to early routine treatment versus conservative management, with rescue allowed. No difference in the primary outcome of ligation or PDA at discharge, none in NEC or BPD, and a worrying trend toward more death in the early treatment arm. Plus, in the more mature subgroup, slower feeds and more late-onset bacteremia and death. Ductus randomized under 28 weekers with a PDA over 1.5 millimeters at 24 to 72 hours to expectant management versus early ibuprofen. Expectant management was non-inferior for the composite of NEC, moderate severe BPD, or death. And there was actually more BPD in the ibuprofen group. Baby Oscar, the largest, 653 infants at 23 to 28 plus 6 weeks with a large PDA treated within 72 hours. Ibuprofen versus placebo showed no reduction in death or moderate to severe BPD, with numerically more death on ibuprofen. 3 different designs, 3 different eras, 1 conclusion. Early routine closure of even a sizable PDA doesn't help and may harm. The big caveat is timing. Most of these enrolled early when spontaneous closure is likely, so they don't answer what to do about the duct that's still significant at 3 or 4 weeks. The NICHD PDA trial may. As concern grew about treating without benefit, conservative or expectant management became common, and it's now the default in many units. It means tolerating a duct that doesn't look significant, allowing delayed spontaneous closure while you support fluids, respiration, and the circulation. The retrospective literature broadly says this is safe, but those studies can't tell us which infants might still have benefited from intervention. The nuance to carry forward is on the right, and it's important. The safety signal may be size-dependent. In the big database studies, the California CPQCC Collaborative and the Pediatrics Data Warehouse, units that reduced COX inhibitor use saw lower BPD in infants over a kilo, but in the very smallest infants, under roughly 750 to 1,000 grams, reduced treatment was associated with increased mortality in some analyses. The Hunscheid systematic review captures the tension. Cohort studies show higher mortality but lower BPD, IVH, and ROP with conservative care, while the pooled RCTs show no significant difference either way. So conservative for everyone may not be right for your 23-weeker. The data are genuinely unsettled at the extremes. Surgery works. Clip or ligation closes the duct reliably with low procedural mortality, and it's done so for decades. The only randomized comparison against medical therapy is Gersony from 1983. Surgery had a 1% failure rate versus 30% for indomethacin, but crucially, no difference in mortality, BPD, NEC, or IVH. More effective at the duct, not at outcomes. The theme again. So why is surgery now a last resort? 2 reasons. First, the complication list. Pneumothorax, wound infection, chylothorax, scoliosis, and especially recurrent laryngeal nerve and diaphragmatic palsy. Second, ligated infants are observationally more likely to develop BPD, ROP, and neurodevelopmental impairment, some of which is confounding by indication, but it tempers enthusiasm. Add the post-ligation cardiorespiratory syndrome, which can need a major escalation of support, though that risk falls over the first 6 weeks. Practically, surgery is reserved for the HSPDA that fails 2+ medical courses, or where drugs are contraindicated. And the epidemiology confirms the shift. U.S. surgical rates dropped from 8.4 to 2.9% over a decade, and transcatheter closure overtook surgery by 2021. Transcatheter closure has moved from an adult and big kid procedure to a real option for preterm infants, and the inflection point is the 2019 FDA approval of the Amplatzer Piccolo occluder, the first device cleared down to 700 grams. The pivotal multicenter study showed 95.5% implant success overall, 99% in infants at or under 2 kilograms, and 99.4% PDA closure at 6 months, with 3-year follow-up showing no new complications and no device or procedure-related deaths. The technical advance that made it safer in tiny infants is the sole transvenous echo-guided approach described by Zahn. It avoids the femoral artery entirely, eliminating the arterial occlusion risk that drove much of the early morbidity. Registry data back this. Arterial access was the dominant predictor of the composite adverse event, odds ratio over 5, and higher volume centers had fewer complications. The chart shows the practice shift. Surgical closure falling, transcatheter rising and overtaking it. 2 honest caveats. Data in the very most immature, 22 to 23 weekers, remain limited. And like every other modality, we still lack RCT evidence that closing the duct this way improves clinical outcomes. The pivotal trial is designed to address exactly that. The supportive measures matter, and each has a trap. Fluid restriction. Early restriction does reduce the incidence of PDA, relative risk around 0.52, and NEC. But that evidence is from trials decades old and may not map onto today's more immature infants. Critically, there's no evidence that restricting fluids helps once you've diagnosed a hemodynamically significant PDA, and over-restriction compromises energy intake and growth. So keep a floor around 120 to 130 milliliters per kg per day after the first week. Furosemide is counterintuitive. Loop diuretics, not thiazides, increase renal prostaglandin E2 and can actually dilate the duct. Prophylactic furosemide trended toward more PDA, not less. It doesn't blunt acetaminophen's closure effect, and a large cohort even linked furosemide exposure to lower odds of PDA treatment. So it's reasonable for managing pulmonary edema, but not as PDA prophylaxis. Ventilation. Higher PEEP and permissive hypercapnia may reduce left-to-right shunting on physiologic grounds, but it simply hasn't been studied well enough to recommend. The meta-message. These adjuncts manage the consequences of the shunt. None is a validated way to make a significant duct close. These are the 6 clinical practice recommendations, the part to actually remember for rounds. 1. No prophylaxis. Any gestational age, any weight. Graded 1A. 2. No early routine closure, whether by drug, catheter, or knife, in the first 1 to 2 weeks, because it closes the duct without improving outcomes. Also 1A. Conservative management in that window lets most infants avoid exposure entirely. 3. And be honest about this one. Beyond 2 weeks, there are insufficient data. So watchful expectancy, attempted medical closure, transcatheter, and surgical closure are all defensible. This is where equipoise lives, and where you'll see the most practice variation. 4. If you do treat a persistent HSPDA after 2 weeks, ibuprofen is the preferred agent, with acetaminophen or indomethacin acceptable. Note, this is only level 5, expert opinion. 5. If it persists despite up to 2 courses or drugs are contraindicated, then consider transcatheter or surgical closure, level 4. 6. Fluids are nuanced. Early restriction may reduce PDA incidence, but there's no benefit after diagnosis, and furosemide is an adjunct only. The through line: do less early, individualize late. Where's the field going? 2 big questions remain genuinely open. First, the link between hemodynamic significance and harm. We still can't reliably say which echo or clinical measures identify the infant whose duct will both stay open a long time and cause adverse outcomes. And tied to that, the optimal timing and method of closure when we do act. Second, a methodological demand the report makes forcefully. Future trials must use clinically important long-term endpoints, not just ductal closure and procedural events, and both arms must be unambiguously defined so a winning strategy can be reproduced. 2 trials to watch, by name. The NICHD Neonatal Research Network PDA trial, around 836 infants, is testing a more selective, later treatment approach, which directly addresses the timing gap left by PDA Tolerate, Beni Ductus, and Baby Oscar. And Pivotal is randomizing transcatheter closure against observation, which is the missing RCT for the procedure that's rapidly becoming first line. Until those read out, the honest position is equipoise, and that's also the ethical argument for enrolling your eligible patients. 5 things to walk out with. 1. Spontaneous closure is the default, even below 26 weeks, so the control group sets a high bar. Never forget that when you're deciding whether to treat. 2. A hemodynamically significant PDA is a composite of clinical and echo criteria, not a number. Use Table 1 as your scaffold. 3. The single most important conceptual point. Closing the duct and improving outcomes are different claims, and the evidence supports the first, not the second. 4. The practical algorithm. Do less early. No prophylaxis, no early routine closure regardless of modality, and individualize beyond 2 weeks, where ibuprofen is the preferred first agent if you treat, escalating to transcatheter or surgery only after failed courses. 5. We are genuinely in equipoise on the hard cases, which is exactly why supporting enrollment in the NICHD and Pivotal trials is the responsible move. Thanks. Let's open it up for questions, and I'm happy to walk through any of the trials in more detail.